Good afternoon, everyone, and welcome to the third part of a five-part series on the webinar series on COVID-19 vaccines. This five-part webinar series is an educational, medical educational session targeting healthcare workers. It is jointly organized by the Malaysian Society of Infection Control and Infectious Diseases, or MyICID, and the Institute for Clinical Research in NIH. I'm Dr. Benedict Sim. I'm an infectious disease physician in Hospital Sungai Buloh, and I'm also the coordinator for the clinical guidelines on COVID-19 vaccination in Malaysia. Thank you for joining us live from five social media platforms. For the question and answer, as usual, please type in your questions in the Slido app. We would try to address as many questions as possible. This is a medical education session, so we will address questions related to this topic. We will not be addressing any policy-related questions, as this will be beyond our scope here. For CPD points, all frontliners, healthcare workers, and allied health teams, remember to collect your CPD points by filling up the online attendance form. In case you missed it, we will broadcast it again after the Q&A session. And please double check your email address before submitting. After the webinar, the presenter slides will be made available on all our social media, websites, and email address. And if you would like to re-watch this session, you can go to our clinical updates in COVID-19 YouTube channel or listen on our podcast channel when it is available. For this afternoon, we are indeed honored and privileged to have three panelists with us from different fields. We have got Dr. Loh Lili, who is an infectious disease physician at Hospital Sultanah Baiyah. We've got Dr. Ong Tian Lee, and a neurologist from Hospital Sungai Buloh, and Dr. Vina Selvaratnam, a hematologist working in Hospital Ampak, to discuss an important topic, which is the side effects and concerns about COVID-19 vaccination. There will be another webinar next week that discusses allergic reactions and anaphylactic reactions to the vaccine. But for today, it is the non-allergic and non-anaphylactic side effects that we will be concerned about. On behalf of the organizers, MyICID and Institute for Clinical Research, NIH, I would like to thank the panelists, Dr. Loh, Dr. Ong, Dr. Vina, for taking the time to join us this afternoon. Our first speaker is Dr. Loh Lili. She's an infectious disease physician in Hospital Sultanah Baiyah. She is a Kedah State Infectious Disease physician and the Chief Coordinator of State Infection Control and AMS Committee. She's also a committee member of the Asia Fungal Working Group under International Society for Human and Animal Mycology, and she's a good friend of mine. Without further ado, I'll now invite Dr. Loh to share her presentation.
Okay. Thank you, Dr. Ben. Good afternoon and Salam Ramadan to all my Muslim colleagues out there. Just let me share my slide first. Hope everyone can see my slide now. Okay. Now, the topic today, as Dr. Ben had mentioned, is about side effects and concerns. Okay. Oops, I can't. Okay, now. So when you're talking about vaccine or vaccine acceptance, we have to look into different perspectives. Number one is the severity of disease. Here, of course, we're talking about COVID-19 disease. So is COVID-19 a severe disease? As a clinicians that been seeing and managing COVID-19, yes, we do see quite a number of patients that develop severe COVID-19 infections that require ICU admissions, and subsequently they complicated with a lot of sequelae. So indeed, it could be a very severe disease when you have COVID-19, especially when you have concomitant medical conditions. Therefore, in this situation, we do need a good vaccine with high efficacy to prevent the transmissions or to prevent cases or people that progress into severe disease when contracted COVID-19. When we have the vaccine, now we need to talk about the safety of the vaccine. So we need to strike a delicate balance in between all these aspects when you consider when we're talking about vaccine. So this is my outline. I'll just briefly recap about the types of vaccine. This is to facilitate our talk in terms of the side effects. So I'll talk a little bit on the side effect or adverse event regards to local and systemic adverse events. And with regards to the adverse events of interest, so I'll just briefly touch on it because my colleagues, Dr. Ong and also Dr. Veena, will bring you through and elaborate on this interesting topic. And then my main task here is to discuss about the pre-vaccination assessment, why we need to have a PVA, okay, and how are we going to do or conduct the PVA. So everyone is familiar with this mRNA vaccine. Okay, because the community or the Pfizer vaccine, the first vaccine that registered in Malaysia, okay, it is important or it's become famous because that it provides very great vaccine efficacy. Even when it tested in a real-world scenario, the effectiveness is almost more than 90%. So this is the data that of this mRNA vaccine from the Israel, meaning the real-world data. It's not only protecting a person from getting the asymptomatic infections, but it's also prevent hospital admissions, as well as prevent a person from progress into severe disease. So the second group of vaccine is inactivated vaccine. Okay, most of us are familiar with it as well. That is Sinovac or CoronaVac. Okay, the efficacy varies from 50 to 91%, although in phase 3 trial, the efficacy is about 50.7%. Now, the third group of vaccine is viral vector vaccine. Okay, this viral vector vaccine has captured the attention right now in the media or in the news. Okay, we have CanSino vaccine from China, Janssen, okay, Sputnik, and also AstraZeneca. All these vaccines are similar in the sense that they're using the adenovirus, okay, so carrying the mRNA spike proteins. The only difference is the serotype of the adenovirus that been used in this and every type of the vaccine. For CanSino is using the serotype 5, as for Janssen is using a serotype 26, as for Sputnik using a combination of the serotype 5 and 26, and AstraZeneca is a little bit special. Instead of using the human adenovirus, is using the chimpanzee virus. So all these vaccines are from the same class, but they are not identical in terms of manufacturing and also the adenovirus. So this is the classifications of the adverse event. Solicited can be divided into localized adverse event or systemic adverse event. Okay, unsolicited it can be adverse event of interest or severe adverse event, meaning that adverse event that may leading into death or permanent disability. So when the committee or the study committee investigate about the adverse event, they will consider few of the factors. One of it, they will compare with the placebo arm to see whether there's any standout signal. Okay, they will also compare with the background rates in unvaccinated populations, and also will take into considerations the persons or the vaccinees or the vaccine recipient, whether they have a pre-existing illness or risk factors that may put them at higher risk in developing the adverse event. So this is the community from Pfizer vaccine. Okay, I just want to highlight here the common side effect, for example, the injection site of pain and also swelling or fatigue or headache is more common after second dose. Okay, more often after second dose rather than in first dose. And usually a person after receiving the vaccine, soon after they may experience the side effect. Okay, it peaks usually around day 1. Subsequently, all the side effects may disappear. Okay, and the side effect is more common among people that less than 55 years old. This is for pertaining to Pfizer vaccine. Okay, this is just a summary of the local and systemic side effect of this community vaccine. And I'm going to share here a case report. 59 years old woman with a known case of right lung CA with metastasis to the ribs. She undergone chemotherapy and therefore proceed with the screening or staging PET-CT. Incidentally, they were found that she had this left axillary limb adenopathy. On further questionings, only noticed that actually she volunteered the history that she received the vaccine 5 days before the imaging. Therefore, in this scenario, it's considered that the left axillary limb node is not significant. It's likely not related to the malignancy disease. So, post-vaccination limb adenopathy is one of the unsolicited adverse events related to the vaccine. Okay, it's possibly related to the vaccine, and it can occur in the neck and also the arm regions. In this journal, New England Journal, it mentions that the reported cases within 2 to 4 days after vaccination, and usually it disappeared within 10 days. So this is another case reviewed by the Spain group, whereby they noticed that around 20 healthcare workers developed supraclavicular lymph nodes in association with the mRNA vaccine. Okay, quite similar. Okay, mainly 1 to day 9 post-vaccinations. Okay, and sometimes it may take longer for the lymph node to resolve, up to 32 days. Okay, but good thing about it is benign, self-limiting. Okay, and it's believed that when a person develops supraclavicular limb adenopathy is associated with the technique of injections, high point injections. So what is important here is mainly if you're dealing or you're treating a person with the malignancy, okay, if you need to subject a patient for imaging, you need to consider these as two factors. If you think that the imaging for screening or surveillance is not urgent, you may want to defer it to 4 to 6 weeks after the injections or the vaccinations, okay? And you probably have to coordinate or talk to the PPV team, mini vaccination team, that try to avoid the injections or the vaccine on the same site that may confuse you later in terms of assessment of the imaging later. Try to inject on the contralateral arm according to the location of the known cancer. So this is the data extracted from the Pfizer study, okay? So during the study, it was actually noticed there was some adverse event, for example, Bell palsy, convulsion, Guillain-Barré syndrome, immune thrombocytopenia that was found in the arm of people that received the vaccine. So when they compared with the adjusted expected event, there was no statistically significant increased risk. So this is what is done usually in study. Okay, it's not in real world, this is in the study. Now, next vaccine is Coronavac or Sinovac. This is a phase 3 trial that carried out in Brazil. Okay, so it's a big disappointment when this data came out, whereby there's only 50.7% efficacy in terms of to prevent systemic COVID-19. Okay, but when you look at the prevention of hospitalization and severe disease, the efficacy is actually very good, almost 100%. So this is a real world experience in Chile about Coronavac. Okay, so in the real world experience, the effectiveness of this vaccine to prevent symptomatic COVID-19, 67%, to prevent hospitalizations was about 85%, and to prevent ICU admission, 89%. Okay, as good as 89%, and to prevent death is about 80%. So there's much discrepancy between the real world experience and the percentage that achieved during trial. And with regards to the local and systemic side effect, okay, in Coronavac, the systemic reaction is more common after the first dose, unlike mRNA vaccine. And next is the AstraZeneca. Okay, this is a vaccine that already caught a lot of attention in the news reporting nowadays. Okay, this is a phase 1, phase 3 trial, and quite similar with Sinovac vaccine, whereby the local and systemic reaction is less common after the second dose. Okay, and it's also less common among elders people, for example, more than 65 years old. Okay, unfortunately, somewhere in March, April, okay, there was signals or safety signal shows that there were vaccine recipients that developed cavernous sinus thrombosis. following that, a lot of extensive investigation being carried out by various parties, including the EMA. So this is the initial reports produced by the EMA, whereby from the 18 cases of cerebral venous sinus thrombosis or cerebral venous thrombosis, mainly affecting women, okay, they are from the age group less than 60 years old. Okay, the time to onset range from 1 to 14 days with a median of 8 days. And there was concomitant thrombocytopenia in 67% of the cases. So when you're comparing the risk of this thrombosis event after receiving AZ vaccine, which is about 5 per million people, okay, whereas the background rates of CVT is around 2 to 5 cases. And bear in mind that the background rates may not be accurate, as this is not notifiable conditions. It's quite difficult to correct a very accurate data when this is not the conditions that people has been paying attention to. So this is quite a recent paper. It's not been published yet, okay, not yet undergone the peer review. It's done by the Oxford University and is carried out in America, the States. Okay, so what they did was they comparing the cerebral venous thrombosis event. It was a retrospective study involving about the 500,000 people that confirmed as COVID-19 cases, as well as people that receive mRNA vaccine, be it Pfizer or Moderna. Okay, again, I emphasize that this study was carried out in America. In US, they do not have AZ vaccine. So the data on your very right column, the data on AZ is extrapolated from EMA reports. So we cannot compare the EMA report head to head with the figures that produced by this study, as they are from the different background and different study protocol. So what they found here in this simple retrospective study was, okay, the incidence of the thrombosis event among the people that infected with COVID-19 infections are much higher as compared to those people that received the vaccine. Okay, 39 events per million people versus 4 events per million people, 10 times higher. Okay, but again, I would like to emphasize that this is a study whereby the cohort is not matched against the age, gender, or the underlying medical conditions. It's just a quick way for them to tease out the data, retrospective data from the electronic database to find out the risk of thrombocytosis if a person were to have COVID-19 infections compared to the background or compared to the persons that received the vaccine. Okay. In such, the EMA again said that the clotting event could be associated with the vaccine, but it's listed as a very rare side effect. It's not common. Okay, 10 times more common to have a blood clot if we were to have the COVID-19 infections compared to receive the vaccine alone. So Sputnik, okay, the other vaccine, acted very fast. Soon after that, they have put up a statement in the website saying that Sputnik have never encountered cases of blood clot thrombosis throughout the rollout of the vaccinations. Okay, it claims that even though they fall under the same class of vaccine, but they have different ways of manufacturing, and also they're using a different type of the virus, adenovirus. Therefore, we should not actually, what they mentions here, it should not actually extrapolate from the study from other vaccine and using on this vaccine. This is a statement by Sputnik. So now, what is the fate of the vaccine, the AZ vaccine right now? Okay, after a study looking at the 86 such cases in EU, the EMA concluded the benefits of the vaccine still outweigh the risk of the virus in terms of hospitalization and death. Therefore, some of the European countries, including Australia and UK, still continue to roll out AZ vaccine, but they put certain clause on it. So most of the country says that it avoid to be used in the younger age group. Of course, there are some countries, for example, Denmark and Norway, they put a definite stop for the rollout AZ vaccine in their country. So it depends on the country policy and the situations there. Now, this is interesting, J&J vaccine. When this vaccine was first introduced, it was thought that it could be one of the most sought after vaccine because it came in a very simple one dosing regimen. Okay. Unfortunately, recently there was data or reports about the thrombosis event among the individuals that received the vaccine. Okay. The incidence is about 6 cases detected in more than 6.8 million doses. Onset is around day 3 to day 13 post-vaccinations, against more common among females in the age that less than 50 years old. So Johnson & Johnson's, the CDC decided to put on hold until they have investigated or they have more data about the safety to roll out J&J. Okay, and this is another latest safety reports about AZ vaccine. It found that there are around 5 cases, 5 persons that develop what they call it capillary leak syndrome, characterized by leakage of fluid into tissue associated with a drop of blood pressure. So it's still under investigations. So we have not much data to share at this moment. So we shall wait for the PRAC to provide the investigations reports. Now, just one slide about post-vaccinations and anaphylactic. So this chapter will be elaborated by our allergists as well as our consultant dermatologists in our next webinar. So stay tuned to our next week webinar if you're interested in this topic. So what I would like to highlight here is, you're looking at the coronavac, AZ, Janssen, Sputnik. During the trial, the anaphylactic reaction is not common when the trial is done among about thousands of patients. But when you roll out in a real world scenario, for example, community and Moderna, this data are based on US data. Actually, they could identify around 4.7 cases per million people that develop anaphylactic in terms of when talking about community. So it just shows that, anaphylactic was not noticeable in a trial, okay, but it's only noticeable during the full rollout when it involved millions and millions of people that receiving the vaccine. So it just shows that it's probably an extreme rare side effect. It could be a side effect, it is a side effect, but it's extremely rare. Okay, but comparing with the incidence of anaphylactic in influenza, of course, the mRNA vaccine, the incidence of anaphylactic is higher. So with regards to AEFI reports, okay, so we would like to encourage people or vaccine recipients to report or self-report the AEFI. So we need to collect more data. Then all the data that is we collected will be useful information for us. It probably will be a safety signal for the committee to raise a red flag to see whether we need to intervene or investigate further. So the vaccine recipients either notify the mild to moderate side effect through MySejahtera. If they do not have MySejahtera, they can approach any of the healthcare facility to fill in the ADR form manually. The healthcare workers or the facilities can actually help the vaccine recipient to fill in the ADR form. Okay. Alternatively, they could actually download the form from the web page and NPRA web page. Just look under the column consumer and look for reporting side effects column. Download the form, then you can actually report it online or fax it or email it or even post it to the given address to NPRA. So as for serious adverse event, usually when you're talking about serious adverse event, the recipient would have been consulted or admitted to hospital. So it is duty of the attending clinicians to do the reporting. As mentioned here, if you think that this is a serious adverse event, you have to notify within 24 hours, subsequently followed by a written report to NPRA. So this will be a duty of the healthcare facilities. So this is a pathway, the algorithm that I have explained earlier. It can be found in our guidelines. So our clinical guidelines on COVID-19 vaccination in Malaysia just been released about a week ago. Okay, you can click on the download link here to download the guideline. It's about 110 pages. You also can refer to the consensus statement by the societies in Malaysia, for example, Hematological Society as well as our rheumatological societies. Now, when we're talking about phase 2 vaccination program, okay, phase 2 is mainly focusing on priority group. Okay, priority group meaning elderly people as well as patients that have got concomitant medical conditions which make them at higher risk of getting severe illness for COVID-19. And some of the people fall under this priority group may need PVA or pre-vaccination assessment. Okay. The aim or the purpose of pre-vaccination assessment is to decide whether the patients can receive the vaccine at any time, any convenient time, or we have to defer the vaccination to a further date. This is more pertaining to people that are on immunosuppressive agents, okay? Or this person is considered not suitable to receive the vaccine at all for some reason, okay? And also we have to decide whether this patient is suitable to receive vaccine in a community vaccination center, or the patient must come to hospital so that the person or the patient will receive the proper monitoring after receiving the injections. It's also very important to elicit the history of severe allergy reaction, for example, allergic to PEG component, which will be elaborated in next week's webinar. So basically, there are 3 groups of patients that require PVA. First group is those people that are immunocompromised. Either they are on chemotherapy, they are receiving some immunosuppressive agents. Okay, so we need to decide about the optimal timing for vaccinations and to inform the patients that there's insufficient data on vaccinations efficacy in view of the immunocompromised status. Okay, but having said so, the vaccine do not interact or have any side interactions with the immunosuppressive agents. Mainly, we worry that if a person's immune system is not normal, the person's immune system is not great or normal, so the response towards the vaccine may not be adequate. Okay, so the second group of persons will be patients with bleeding tendency or patients that are on medications which may make them more prone to be bleeding. Therefore, we need to have a hemostatic precautions. And the third group will be those people that has got significant history of severe allergy reactions or allergic to multiple classes of drugs. And this group of people certainly will need to receive the vaccine in hospital setup, whereby we will impose all these allergic reactions precautions. They will be monitored for a longer period after receiving the vaccine. And I put up the 4th group here, mainly is line or others, for frail elderly patients or people that with terminal illness, but yet they are not actively deteriorating, whereby they may still be benefited from the vaccine. So timing for vaccinations, okay, all this can be found in our guideline. I just put out a few common scenarios that people often ask. Can a person that with acute illness receive the vaccine? Yes, the answer is yes, but you have to defer the vaccine until the person has fully recovered from the acute illness, meaning discharged from hospital, then they are well. Okay, can a person who previously had COVID infections receive the vaccine? The answer is yes, but you have to wait until the person already recovered from COVID-19 infection, being discharged already, okay, discontinue isolations. And theoretically, because post-infection, they should have at least 3 months of natural immunity. So in that scenario, it's not an urgency to put them under the priority group. You can actually defer them for vaccination up to 3 months from the time, counting from the time that they have the infections. Okay. Now, for persons who's been quarantined or at quarantine center under the HSO, okay, being a close contact, you can consider for vaccinations after the person has completed the quarantine and they are considered to be asymptomatic, meaning they do not have active infections at the point in time. You can consider to list them as the vaccine recipient. Now, for a person that recently have received any kind of vaccine, be it the influenza vaccine or hepatitis B booster, you need to delay the vaccinations until 2 weeks. Okay, so meaning the intervals between the 2 different types of vaccine, it has to be a minimum of 2 weeks. Okay, and for persons that are on anticoagulant or antiplatelets agents, okay, In the presence of warfarin, as long as the usual INR monitoring is less than 4, the person may go ahead with the vaccinations, okay? But we advise that on the day of vaccinations, okay, to only take the warfarin, the DOAC or lower molecular weight heparin only after they have received the vaccine injections, not before. This will delay. You don't have to miss any dose, just take the medicine after the injections. Now, for individuals who are receiving immunosuppressive or immunomodulating biological agents, please discuss with the healthcare provider regards to the optimal timing for vaccinations. Don't deny them from the chance of getting the vaccine, but have to discuss with the healthcare provider as they know the conditions better. So make your choice, okay? Which one on the right or the left that depicted in the comics. Okay, we hope that with the increased uptake of vaccines in the country, it will be something like this, that picture here in Israel. Okay, then you know that as Israel is one of the first countries that rolled out vaccination program, the good uptake there. Subsequently, you can see that the number of people that contracted the COVID-19 disease reduced significantly. And the number of people that require mechanical ventilation reduced. So ICU bed is one of the very important resources. Not only we have to cater for COVID-19, we have to COVID for non-COVID-19 patients. So it's very valuable resources to us. Again, that is my last slide. With that, I pass it back to Dr. Ben.
Thank you, Dr. Loh, for that insightful presentation. Now, I'm sure you will have questions for Dr. Loh. Please type in your questions in Slido. We will only start answering the questions after the third presentation in the interest of time. Yeah. So our next speaker is Dr. Ong Tian Lee, who actually works with me here in Hospital Sungai Buloh. She's a neurologist here. She's got 14 years working experience and is currently in the neurology subspecialty since January 2017. She has been gazetted as a physician in internal medicine in 2016, completed her fellowship training in movement disorders in Westmead Hospital in September 2020. Without further ado, I would like to invite Dr. Ong to share her presentation. Dr. Ong.
Thank you, Dr. Ben. Let me share my slide. Good afternoon, everyone. I'll be talking on the possible neurological complications following COVID-19 vaccine. And this is my disclaimer. And the content of the topic basically focus on the common and uncommon neurological manifestations. I'll be talking in general what are the neurological features that we should know, but will not focus on individual case reports. And the purpose of this presentation is to share knowledge on what we know as well as what we don't know. Hopefully that when these cases present at the primary care setting or in the emergency department, these cases can be picked up quickly and referred to the appropriate team for further management. So let us dive immediately on the common neurological side effects for all vaccines. Headache is the common neurological side effect as mentioned by Dr. Loh earlier. It is, however, short-lived, self-limiting, and usually lasting about 24 to 48 hours. And commonly in mRNA vaccine, it is more so after the second dose of vaccination. And CDC actually recommends against the use of NSAID or acetaminophen as prophylaxis prior to vaccination. There is a concern that NSAID may inhibit enzyme cyclooxygenase 1 and 2 and may modulate immune response to COVID-19 vaccine. In addition, antipyretics were said to be able to reduce measured antibody response to vaccination in infants, and that's why CDC comes up with the recommendation. However, there's no specific studies done so far to address this concern with regards to COVID-19 vaccination. In fact, in the AstraZeneca clinical trial, several sites actually use prophylactic analgesia, paracetamol, with no apparent detrimental effect on the subsequent antibody response. And therefore, if headache develops after vaccination, the use of NSAID or acetaminophen are not contraindicated and would be considered first-line treatment. In certain patients with migraine may flare up. And some patients may even develop visual aura for the first time after immunization. They usually last approximately 3 to 5 days. And migraine patients who are on triptans, CGRP, and other treatments can continue with their treatment during COVID-19 vaccination. And if, let's say, one of our patients presents to us with atypical headache, let's say the headache presents manifestation with facial involvement, forehead pain, eye pain, perhaps you should consider there's a possibility of herpes zoster reactivation. There's an observational study monitoring post-vaccination adverse event in 491 patients with stable autoimmune inflammatory rheumatic disease. This patient had rheumatoid arthritis and Sjogren's. There are 4 patients in these 491 patients developed first episodes of herpes zoster, and most of them developed after the first dose. And one of the patients among these 6 patients had herpes zoster ophthalmicus, presenting a severe intense headache with rash on the forehead. And therefore, in susceptible individuals, perhaps we need to consider this differential diagnosis if there is atypical presentation of headache. However, so far there is only one paper published addressing this condition in autoimmune in patients with autoimmune inflammatory rheumatic disease. Whether or not a similar condition can be observed in other autoimmune inflammatory disease, we are unsure, and we might need to wait for more evidence and further publication on this particular topic. The concern about neurological complications from COVID-19 vaccination escalated in the end of 2020 when transverse myelitis was reported in 3 patients during AstraZeneca vaccine trial. And transverse myelitis is inflammation of the spinal cord. Patient can present with lower limb weakness, bowel and bladder dysfunction, as well as sensory level. So in a paper published by the Lancet Neurology in January this year, in 12,000 recipients of Oxford AstraZeneca COVID-19 vaccine, there's 1 patient who developed transverse myelitis occurred 14 days after the vaccine dose. It involves a 37-year-old woman with no prior medical problems. The 2 additional cases were considered unlikely related to the vaccine because one had pre-existing multiple sclerosis and the other occurred in the control group. And therefore, this one case reported, we are unsure whether it is coincidental or there is association with the vaccine. As for Bell's palsy, there are 7 cases of Bell's palsy reported in the 37,000 mRNA vaccine recipients, 4 from Pfizer therapy and the other 3 from Moderna. 6 of them occurred after the second dose. The FDA observed the frequency of Bell's palsy is consistent with the expected background rate in general population. However, there's an imbalance in the incidence of Bell's palsy following vaccination compared with the placebo arm. In the case of Pfizer, there's 0 cases reported in the placebo group, but 4 cases in the vaccination group. And therefore, FDA recommends we need to look into this again. And in post-marketing vaccination, so far there are 2 cases reported. One involved a young man in his 30s, developed Bell's palsy 5 days after his first injection, and the other is a lady in her 50s who had recurrent Bell's palsy, developed facial palsy a couple of days after the second injection. For Guillain-Barré syndrome, data from mRNA vaccine clinical trial showed no participant developed GBS in the trial. And for post-marketing case report, there is 1 case published in February this year describing an 82-year-old female presented with generalized body ache, paresthesia, and difficulty in walking 2 weeks after the first dose of Pfizer COVID-19 vaccine. Fortunately, the lower limb weakness was not severe, and she improved after IVIG therapy. The estimated risk of GBS in the world is approximately 1 to 2 cases per 100,000 people per year. and the lifetime individual risk of acquiring GBS is 1 in 1,000. So within 1 billion people, 17,000 cases of sporadic GBS per annum can be seen, and approximately 1,900 can present in any given 6-week period. If we are to vaccinate about 4 billion persons in 1 year, 68,000 cases of GBS would be expected to occur naturally within this time period. And of these, 13,000 would occur in the 10-week window period of the double dose vaccine. Therefore, it is inevitable that these sporadic cases will appear temporarily associated with COVID-19 vaccine. There are multiple other vaccines previously alleged to be associated with GBS, such as hepatitis B, polio, and tetanus, but there are no causative links have been conclusively proven despite these individual reports being widely quoted. And CDC has stated that the Independent Advisory Committee on Immunization Practices do not include a history of GBS as a precaution to vaccination with other vaccines. However, let's look at this Sinovac, CoronaVac contraindication list that is in their template. The clause number 3, individuals with severe neurological conditions. In this, examples given are transverse myelitis, Guillain-Barré syndrome, and demyelinating disease. Of course, patients with acute transverse myelitis, acute Guillain-Barré syndrome, and acute demyelinating diseases, these are all severe neurological conditions. If patients present with acute condition, treatment should be given to these patients first, and vaccination as such will not be suitable. As in the case of EDEM, EDEM represents acute disseminated encephalomyelitis. It is a central nervous system demyelinating disorder. It is said to have been associated with several vaccines like rabies, smallpox, and MMR. For most vaccines, the incidence rate is reported to be at 0.1 to 0.2 per 100,000 vaccinated individuals. However, there are only 5% of cases of EDEM are preceded by vaccination within 1 month prior to symptom onset. And so far, post-marketing, there is only 1 case report published in which a lady with no prior medical problems received inactivated COVID-19 vaccine, developed acute disseminated encephalomyelitis. This, the MRI on the right showed you, is published in the journal, showing the areas of demyelination pointed by the red arrow. The patient recovered following IVIG treatment. For acute ischemic stroke, in Pfizer phase 3 trial, approximately 38,000 participants randomized to 1-to-1 vaccine and placebo with a median 2-month follow-up after dose 2. None of the patients died of central nervous system related complications, and only 1 participant in older placebo group had hemorrhagic stroke 15 days after dose 2 and died the following day. As for Sinovac trial, the phase 1 and phase 2 published information documented no serious adverse events reported in all the participants. To address the issue on hypertension after COVID vaccine, there's a published paper on American Heart Association describing stage 3 hypertension in patients after mRNA-based SARS-CoV-2 vaccination. It is a case series involved 9 patients, 7 females and 2 males. They all developed stage 3 hypertension within minutes of vaccination. 8 of them are symptomatic. However, 8 of these patients had prior history of arterial hypertension, and most of them are on antihypertensive medication. However, the dose and type of medication was not mentioned in the paper. 8 of the patients received Pfizer, 1 had Moderna, which was just introduced. One of the limitations of this paper is there was no pre-vaccination blood pressure value documented. But the paper suggests that a fraction of hypertension patients may react with symptomatically significant increases in both systolic and diastolic blood pressure. But they acknowledge that more data will be required to affect our clinical practice. But they do raise the concern that pre-vaccination control of blood pressure is very important. And there might be a need to monitor for post-vaccination monitoring and symptom screening for elderly with hypertension, with history of hypertension, or significant prior cardiovascular risk factor. Moving on to the most popular topic of the day, cerebral venous sinus thrombosis, CVST. It is uncommon, around 0.22 to 1.57 per 100,000 patients. It constitutes about 0.5 to 1% of all strokes. Bear in mind, this is CVST rate in general. For CVST with thrombocytopenia, it is very rare. The median age of patients presenting with CVST is around 37 years old, female more than male, and the risk factors identified are oral contraceptive pills, pregnancy, postpartum, malignancy, and infection. Signs and symptoms. More common presentations are those that indicate increase in intracranial pressure, such as headache, vomiting, papillary edema, and visual problems, focal neurological signs, seizures, and encephalopathy. The uncommon presentations are subarachnoid hemorrhage and cavernous sinus syndrome. The additional characteristic of patients with CVST and thrombocytopenia after Janssen COVID-19, apart from those mentioned by Dr. Loh, one of the patients had estrogen and progesterone use during the event. 3 of them were obese, 1 had hypertension, 1 had hypothyroidism, and 1 had asthma. This is a table to show you the summary of all the 6 patients, to tell you that the initial features of all these patients, presenting features are actually headache, except for 1 patient, patient number 6, presented with back pain. And the late features, some of them had focal neurological signs. As you look at the location of the CVST, there are multiple areas of sinus, venous was thrombosed. And the commonest one is transverse sinus, followed by sigmoid sinus. Some of the patients had bleeding as well. And the subsequent column shows you that the platelet counts of all these patients range from 10,000 to 120,000. So this is an illustration of the areas of venous thrombosis reported in patients with Janssen COVID vaccine. The superior sagittal sinus, inferior sagittal sinus, sigmoid, transverse sinus, convolutus, and straight sinuses and straight sinus. Moving on to the AstraZeneca vaccine, I won't be talking too much on the investigation and treatment, as Dr. Vina will be going in depth on that. But I just want to highlight that the median age again is of younger population, 36 years of age, range from 22 to 49 years old. Onset is for day 5 to day 16. Whereas for those patients from Norway, there's a table here to highlight the age of them, 37 years old to 50. Females, 4 of them, and 1 male. And all of the females had cerebral venous thrombosis, whereas the male didn't have CVT. The time of onset from vaccination to admission was towards the end of the 1st week, entering 2nd week. And again, the location of thrombosis in the cortical sinus, and there are multiple transverse sinus and venous sinuses involved, similar to those seen in Janssen. Platelet count, again, ranging from 10,000 to 70,000. And that's the end of my presentation. I just want to, for final message, common side effects are usually common. Common things are common. And if they present, they are usually short-lived and self-limiting. If they occur for a prolonged period of time, especially in terms of headache, and if there are red flag syndrome, indicating there's clue of increased intracranial hypertension, perhaps we should remember what some of the neurological issues that I have presented, and perhaps we can pick them up early and refer them to the appropriate treatment, and at the same time, remember to report them to the authorities. Thank you very much.
Thank you, Dr. Ong. Again, if you have any questions, please type in your questions in the Slido. And our final speaker for today is Dr. Veena Selvaratnam, who is a hematologist working in Ampang Hospital. She's got a string of other she's modestly asked me not to read out all her other things that she's involved in as well. So Dr. Veena, the stage is yours.
Thank you very much, Dr. Ben. I'm just going to share my screen now. Okay, all right. I hope y'all can see my presentation. A very good afternoon to everyone. I know we've come towards the end. Just bear with us. This is the last presentation. I've been given the task to actually speak on the vaccine side effects, which is essentially hematology related. And this is my disclaimer. Whatever that we are presenting today, or I'm presenting today, is what we know of today, which is 21st of April. So hematology related basically has got two important topics as far as the vaccine is concerned. One is vaccine-induced prothrombotic immune thrombocytopenia, or also known as vaccine-induced immune thrombotic thrombocytopenia. And the next is immune thrombocytopenic purpura, which is related to the vaccine. Now, I'll talk a little bit on the history of VITT, which is essentially the hype now. The history began on March 10, 2021, wherein the European Medicines Agency reported 4 cases of thrombosis in Austria. And very soon after, similar reports were gathered all around Europe. And by the 31st of March, the UK's Medicine and Healthcare Products Regulatory Agency had received about 79 reports of thrombosis. And of that, interestingly, 44 were cerebral venous sinus thrombosis. However, by then, millions of doses of the AstraZeneca vaccine, which was thought to be the culprit, had been administered worldwide. And it's important to note that some countries had no reported incidents of thrombotic complications. Now, moving on to how this vaccine-induced thrombotic thrombocytopenia antibody was identified to begin with. So because it was in the Europe and that part of the world, it was initially investigated by the German researchers from the Paul Ehrlich Institute, which was led by Dr. Andreas Grenacher. And he studied serum from 31 patients that were collected all over Europe because he had asked them to send those serums back to him. And these patients presented with thrombosis and thrombocytopenia post-vaccine. And they noticed that in this institute, the majority of these patient samples contain antibodies that mimicked the heparin-induced thrombocytopenia antibodies, which were detected via the ELISA assay. And some of these assays, some of these serum gave a positive HEPA or heparin-induced platelet aggregation test that was positive. And those that were not positive had a positive modified HEPA test. So this is the algorithm that was published by the German group, right? So they just said they noticed that patients who had thrombocytopenia thrombosis, they looked for the antibody via the ELISA, and then subsequently went and did the functional assay. Now, since we don't know very much about VITT, but we know much more about HIT. Now let's just see what HIT is all about. So essentially, it's a development of antibody against the heparin PF4 complex. So that's the antibody against that complex. And it develops about 5 to 10 days post-heparin exposure, very much the same duration as post-vaccine exposure as well. All right. So the suspicion is based on a clinical predictive score called the 4T score. And essentially, as the vaccine-induced thrombocytopenia, the confirmatory test is to detect the antibody that is against the heparin PF4 complex. And you can also do a functional assay, which is the HEPA, the serotonin release assay, as well as a platelet aggregation test. And how do we treat this condition? Essentially, we know heparin is a culprit, so we stop the culprit and we find alternative anticoagulation for the patient. So as you can see, this diagram just shows that for HIT to occur, you need the presence of PF4 and heparin, which forms a complex, and that binds the antibody that is present in the circulation or develops after develops after heparin exposure. And this heparin antibody antigen complex then goes and causes platelet activation, and therefore you have thrombosis. Uncontrolled platelet activation causes thrombosis. Now, moving back to vaccine-induced thrombotic thrombocytopenia, what do we know so far? Essentially, what we know is that the general reported incidence of thrombosis is similar before and after vaccine. So there's nothing really alarming if you look at the general reported incidence of thrombosis. However, there is an apparent risk of HIT-like thrombosis present, whereby there is thrombosis in the presence of thrombocytopenia. And this happens to occur about 4 to 20 days post-vaccination, with an average of 14 days post-vaccination. And what is important or interesting to note is that the cases of thrombosis at unusual sites are relatively higher. As we can see, more cases of cerebral venous sinus thrombosis as well as splenic vein thrombosis have been reported. Having said that, there are also instances of arterial thrombosis seen. And one more important or interesting criteria is that it tends to be seen more in the younger female population, as has been alluded in the previous presentations. So now the incidence of VIT. What is the incidence? Once again, this is a moving target. It keeps changing from day to day, but it has been generally reported that there has been 9 cases of vaccine-induced thrombotic thrombocytopenia seen in 7 million doses given, and this was reported on the 20th of April. As for the AstraZeneca vaccine, there have been about 220 reported cases in 34 million Europeans vaccinated. But having said that, this is reported cases, not confirmed cases. And generally, people say that the incidence of VITT associated with AstraZeneca is about 5 in a million, right? And this incidence has not been established yet with the Pfizer or the Moderna vaccine. Now, why does this happen? Well, we really do not know, but these are the biological possibilities. Basically, some feel that is perhaps a direct relationship to the adenovirus vector that has been used, or a reaction to the spike protein. So as we know, the AstraZeneca uses a chimpanzee adenovirus, and that perhaps may directly bind to the platelet platelet factor 4 that is present in the body and causing this activation. But having said that, the viral quantity is very, very small, so makes it a little bit less unlikely, but it could be a potential trigger. The adenoviruses itself is known to cause thrombocytopenia, increase von-Willebrand factor antigen, as well as platelet activation. So it's still possible. And free DNA in the vaccine form multi-molecular complexes with platelet factor 4, and therefore this binding to antibody in patients with previous history of HIT or induced antibodies against heparin PF4, which is seen in mice models. But once again, this hypothesis is assuming that these patients have been exposed to heparin in the past and have had HIT in the past. Which is also something that we don't see in our patients. So this is, once again, a hypothesis. Of course, the second hypothesis is perhaps there may be a reaction to the spike protein itself. But having said that, there have been studies comparing the immunogenic epitopes of PF4 and the spike protein before, and this makes this hypothesis, and the reaction is not as what we see, and therefore makes this hypothesis less likely. So in short, we really do not know. So the difference between HIT and VIT, since there's so much a similarity that has been found, it's important that we differentiate this. Okay, so HIT, as we know, is related to heparin exposure, whereas vaccine-induced, it is not related to heparin exposure. In HIT, the antibody is directed against the heparin PF4 complex. So you need to form a heparin PF4 complex. In the absence of heparin, there is no heparin PF4 complex and there is no thrombosis. Whereas in vaccine-induced thrombotic thrombocytopenia, the antibody is only against platelet factor 4. So you don't need the presence of heparin to be there. In HIT, usually the HIPAA test is positive, the heparin-induced platelet aggregation test is positive, whereas in VIT, based on the initial German studies, some of them have positive HIPAA assays, and those without a positive HIPAA assay, there was a modified HIPAA test that was done, and that was known to be positive. So you can have both positive HIPAA as well as modified HIPAA test. Okay, so in patients with HIT, which is heparin-induced, there is a apparent allergy to heparin or hypersensitivity, and these patients usually, when they are injected with heparin, they tend to develop a hypersensitive reaction or an allergic reaction. It could be an injection at the site or a systemic kind of like a bronchospasm or angioedema or some sort of allergic reaction. Of course, this is not a very common thing that you see, but it's still possible. Whereas in VIT, there is no heparin allergy or hypersensitivity. In HIT, both small vessel and large vessel thrombosis have been reported, and whereby in HIT, patients also present with skin necrosis, so the capillaries also get thrombosed. But having said that, in VIT, it seems to be that majority of the vessels involved are large vessels. It can be either arterial or venous, but we don't, I mean, so far there's no reports of skin necrosis to the best of my knowledge. And lastly, in HIT, further heparin therapy is absolutely contraindicated, whereas in VIT, the relationship to heparin therapy is still unknown, all right? So when do we suspect VIT? Essentially, you need to have a recent vaccine administration, and there are some papers that say less than 28 days. There's some papers that says, recent, but essentially we say less than 30 days, and generally, usually more than 3 days. So between 4 to 30 days would be the best duration. And most of them have prolonged periods of being unwell. So we all know that, I mean, having had the injections, most healthcare workers know that after the second dose, we have generalized body ache. Some people have flu-like symptoms and all that. So it usually lasts for 48 hours or less. But if you have these symptoms that persist more than 48 hours, 3 days and beyond, then you need to, look carefully and take these patients seriously. All right. So what are the symptoms? The warning signs are essentially, as been alluded before, you need to look out for headache, things of blurring of vision, usually neurological signs, nausea, vomiting. Patients can come in with seizures. And those presenting with splenic vein thrombosis then can present with abdominal pain, also nausea and vomiting, right? And of course, they can also have pulmonary embolism or cardiovascular disease. So you can have chest pain, shortness of breath, even DVT. So look out for lower limb swelling. And occasionally, instead of thrombosis, when they go into consumptive coagulopathy, because all essentially DIC, when you activate your clotting cascade, you eventually tend to bleed. So you need to look for bleeding, petechiae, and so bruising, and so on and so forth as well. All right, and majority of these patients with VIT have been reported to have thrombocytopenia, definitely platelet count less than 150. They can present with or without thrombosis. And because there is underlying subtle DIC, because there's an activation of the coagulation cascade, the D dimers are very raised, and usually D dimers are more than 4,000. All right, and they usually have low or normal fibrinogen, not high fibrinogen. So this is the algorithm you can see many associations, they have actually come up with an algorithm on how to investigate. So if you have to suspect VITT if a patient has been recently vaccinated, which is less than 30 days. They present with warning signs that has been mentioned prior to this, and they usually will have thrombocytopenia, signs of thrombocytopenia or thrombosis. And what do you do next? You send for a full blood count looking for thrombocytopenia, and a full blood film basically to look whether these thrombocytopenia is a true thrombocytopenia. So once again, because you will have true thrombocytopenia. So you rule out platelet clumping and so on and so forth. The D dimer will be very, very raised, and you need to send a coagulation screen as well, because sometimes they can go into consumptive coagulopathy. So occasionally, if they come in very late, the PT and the APTT can be prolonged as well. Fibrinogen is another test that has been recommended, once again, to look for DIC, and fibrinogen is meant to be either normal or low. But this test may not be readily available in all hospitals, but it's something that, if you don't have it, it's fine. But if you have it, it's great. And of course, look for evidence of thrombosis or bleeding via imaging. So a CT brain or a CT abdomen with inclusive of with contrast, basically, because you're looking for thrombosis if possible. And once you have all this, then the confirmatory diagnosis is essentially to look for the antibody against PF4. And it has to be ELISA based. Ideally, we think, basically, because it's labor intensive, ELISA based assay, and it's perhaps the incidents are very low. Perhaps something that is centralized will be more cost effective than doing it in every hospital. Okay, so the clinical subgroup based on the results or the symptoms that you have. So you have an onset, anything more than 30 days is not VITT. You may not have thrombosis. If the platelet count is more than 150 and the D dimer is very low, this makes the suspicion of vaccine-induced thrombotic thrombocytopenia very, very, very low. And if especially so if the fibrinogen is normal or high, right? But if you have, of course, conversely, if you fall into the duration of 4 to 30 days, with or without thrombosis, doesn't matter, with thrombocytopenia and very, very high D-dimer levels, as well as normal or low fibrinogen, then this makes the suspicion of VITT extremely high. And of course, you can say highly probable VITT. You need to confirm it via doing the PF4 antibodies, right? The anti-PF4 antibodies. And somewhere in between there, when you have a bit of a gray zone, which is probable VITT, you firstly, you still need to investigate. You can send for the antibodies because it falls under the gray zone, or call for help if you are in doubt. Okay. So how do you detect this anti-PF4 antibody? Just a brief introduction. There are many established tests that are available for HIT, for heparin-induced thrombotic thrombocytopenia. You have the ELISA method, the particle agglutination method, as well as functional assays. And most rapid tests are designed to detect the heparin PF4 complex. So there are some rapid tests that are available for the HIT, for HIT detection, essentially to detect just the heparin PF4 complex. However, for VITT, there is no association with heparin and therefore no heparin PF4 complex. And the antibody is directed exclusively against platelet factor 4. And therefore, only the ELISA assay as well as the functional assay have been shown to be associated with VITT. So I just want to emphasize that essentially you need to look for an ELISA test. You need to do the ELISA test, which is the antibody test, and not a particle agglutination test or a kind of like a rapid test when trying to look for these anti-PF4 antibodies, because in the European countries, it has been shown that this antibody was not detected using these rapid test methods. All right. So once we run this test in Hospital Ampang, so I can let you know that usually one kit can run about 30 samples at one run, and we offer it in the MRKH in Hospital Ampang. And I mean, we are happy to do this if we get, we have to do some amount of additional training and maybe some additional funding to do this. But when we do offer it as for suspicion of VITT, what we suggest is that we get 2 plain tubes and 1 EDTA from patients, suspected patients. It ideally has to be a fresh sample, which is less than 4 hours age-wise. So from drawing of the sample to receiving it at the lab, it ideally has to be less than 4 hours. And if it cannot reach our lab within 4 hours, then we would suggest that the sample be spun, freeze, and sent frozen to us. It's meant to be kept at night between -20 to -80 and sent frozen in dry ice to us. And we have suggested, or we have discussed that we will run it once we reach 30 samples, or once a week, whichever comes first. And of course, this is subject to change, depends on the supply and demand to a certain extent. So if we have more demand, then of course the frequency will be higher. And if we do it only once a week, then the expected TAT is 5 working days. But however, if we run it more frequently, then the TAT will be lesser. All right. Now, so that is in terms of making the diagnosis or the confirmatory diagnosis of the VITT. How do you manage a patient? Now, once again, I would like to emphasize that with the clinical suspicion, you should start treatment. Don't wait confirmatory diagnosis. If you have a strong clinical suspicion in the presence of thrombosis, just treat. And how do you treat them? You give very high doses of IVIG urgently as soon as possible. And the recommended dose is 1 gram per kilogram for 2 days. It is recommended to avoid platelet transfusion because you know that the platelets are the problem. So you give more platelets, you may cause more problems. However, if you do need to administer platelet for whatever reason, please administer it after or with IVIG concurrently. Now, many guidelines have actually recommended to avoid heparin, but once again, there is no clear association between heparin and VITT. This advice of avoiding heparin is basically based on what we understand from HITT. But once again, there's no clear association. But for now, to be on the safe grounds, we have suggested, or it has been suggested, that we have to avoid heparin. And if the patient has got thrombosis, the safest thing is to start non-heparin anticoagulant. And of course, this is on the basis of balancing the bleeding versus the thrombosis risk. So if the patient has got a massive bleed, then you may want to hold back a little. But if the bleed is because of a thrombus, then you still need to start anticoagulation at full dose. Okay. So before starting anticoagulation, it has been advised to make sure the fibrinogen is kept at more than 1.5 gram per deciliter. How do you do that? You transfuse cryoprecipitate here in Malaysia because we do not have fibrinogen concentrate at the moment. In the event that IVIG cannot be given urgently, you can administer steroids, or you can also administer steroids concurrently with IVIG if you think the case of VITT is very, very severe. It has been said that plasma exchange may be useful. Essentially, this is in the concept of you're removing your antibodies that are problematic, and it's recommended that you use plasma and not albumin. So I guess the rationale of using plasma is that so that you can also replace your fibrinogen at the same time, and therefore, it's killing two birds at one go. All right. Antiplatelets and thrombopoietic agents, agonists, should be avoided in these cases. So a little bit more on management of the anticoagulation. So basically, you're meant to use non-cross-reacting anticoagulant, and the non-cross-reacting anticoagulant that are available worldwide is fondaparinux, narapride, agatrovan, and DOAX. But in Malaysia, you only have fondaparinux and DOAX. So these are the two options that you can use. Of course, in a patient who is severely ill, perhaps you would probably choose the parenteral anticoagulant as compared to the oral anticoagulant. So perhaps fondaparinux might be the anticoagulation of choice. Okay. However, there's no clear evidence, once again, to suggest relationship with heparin use at the moment. So for the moment, we say don't use heparin, but this may change in the future. And once again, as I mentioned earlier, when you're using anticoagulation, try and keep platelets more than 30 and fibrinogen more than 1.5 gram per deciliter. Keeping platelets more than 30 is to give IVIG and transfuse platelets, and fibrinogen is by giving cryoprecipitate. So in the presence of thrombosis, you should give the patient a treatment dose of your anticoagulant. And this is meant to be continued for a total duration of 3 months and then stop. Once again, this is extrapolated from what we know from HIT, right? And in the absence of thrombosis, prophylaxis dose is sufficient. And if you think that the antibodies have settled and has calmed down, usually thromboprophylaxis is recommended for a total duration of 6 weeks, or while the patient, or in fact longer if the patient is still in hospital. Okay, so key points to remember when managing VITT. If the patient needs a neurosurgical intervention, that shouldn't be delayed if it is deemed necessary. As I mentioned earlier, if you need to transfuse platelet, please transfuse platelet, but give IVIG before or during platelet transfusion. So if the patient presents with an arterial thrombosis and it was in a healthy patient who did not have any history of atherosclerosis in the past, anticoagulation is the preferred method of coagulation. And you can eventually switch to antiplatelets when the fibrinogen and the D-dimers and platelets have normalized because you're dealing with the arteries. And if you're dealing with a patient where the bleeding risk and it's a bit dicey, the bleeding risk and the clotting risk is a bit dicey, then you can use a lower dose of fondaparinux or DOAX initially, and then subsequently increase to either treatment dose or prophylactic dose later, a full treatment dose or full prophylactic dose later when they are better, as these patients are highly prothrombotic. And once again, the second dose of vaccine is contraindicated in these patients. All right. So this is all I have about VITT. Now moving on to immune thrombocytopenia purpura, which is vaccine related. All right. So this has been reported in case series with the Pfizer and Moderna vaccine. It is once again extremely rare. And there's no clear relationship with VITT at this point in time. Right, the onset is about between 5 to 23 days post-vaccine, and it has been seen in patients with previously unknown to have ITP, though it has been postulated that it can temporarily worsen patients with underlying ITP, but this is just a postulation, right? And patients present mainly with bleeding symptoms, which is essentially petechiae, bruising, mucosal bleeding. And what is important to note is actually the platelet count with ITP, it's seen in ITP, which is vaccine induced, is actually much, much lower than the patients with VITT, because VITT also presents with thrombocytopenia, but the ITP with vaccine, you can actually see platelets up to single digits. So it can be much, much more severe in terms of thrombocytopenia. And the treatment is essentially the same, which is IVIG steroids, and some case reports have even used rituximab, right? So in severe bleeding, when you're dealing with ITP, then platelet transfusion is advocated with concurrent administration of immunosuppressive agents. And it's just to bear in mind that when you use aggressive immunosuppressive agents, this may jeopardize the immune response required for antibody production intended for the vaccine, because you are causing immunosuppression, so you can't mount an immune response. So that may jeopardize the whole idea of the vaccine. But having said that, you have no choice but to do it. And so it's good to bear in mind that these patients may not be protected, right? And whether second dose of vaccine should be administered in this cohort of patients remain unanswered, perhaps will depend on the severity of the initial response, and the patients may require an informed consent. I don't know, but it's still a little bit gray. Okay, so how do you manage a patient with underlying ITP? Because there have been some postulation that it may worsen ITP. So there's no clear evidence to show that ITP will worsen. It's just a postulation, and some reported cases show that there was a transient worsening of thrombocytopenia. And this is just a suggestion. Basically, you can take a baseline FBC before vaccine administration, ensure the platelet counts are more than 50. This is in the Malaysian Society of Hematology recommendation as well. Ensure that the platelet counts are more than 50, and tell your patients to watch for signs and symptoms of thrombocytopenia. So if they've got worsening petechiae or mucosal bleeding or bruising, then come to the hospital and seek advice immediately if these new bleeding symptoms occur. So I've come to my last slide of my presentation. In conclusion, there's significant temporal relationship between vaccine and vaccine-induced thrombotic thrombocytopenia as well as ITP. And the best thing is that the treatment for both are the same. So we both of it, you give IVIG or steroids, essentially immunosuppressive agents. Clinicians should always have a high index of suspicion in order to be able to pick this up in patients that present to you. There's a saying that says the eyes doesn't see what the mind doesn't know. So basically, you need to have a very high clinical suspicion. Please report all suspected cases. Reporting is very, very important, because if you don't report timely, then there will be underreporting, and we really wouldn't know the real incidence of the real world data, right? So it's okay to over-report occasionally so that investigations can be done. And please call for help when in doubt. With that, I thank you very much.
Thank you, Dr. Veena. Okay, so we have come to our time for the Q&A session. We probably got about 15 minutes or so to handle the questions. Now, please put in your questions via Slido, and we will try to answer as many of these clinical questions as possible. As mentioned earlier, we will not be addressing any policy-related questions, as this would be beyond our scope of clinical practice. Yeah. So I will go to some of the questions that have already made its way up Slido. I see one question for Dr. Loh. Dr. Loh, for HIV patients who are currently treated with heart therapy, will the drugs affect the potency or efficacy of the vaccines?
Okay, I'll take the questions. Now, with regards to HIV patients that are on treatment, there's no drug-drug interaction per se between the vaccine and the ARVs. So, but what we need to explain to the patient is if they have a very low CD4 count, what we don't know is the efficacy of the vaccine, because your body may not be able to more adequate respond towards the vaccine because of the low CD4 counts. But there is no drug-drug interactions.
Okay, the next question I will also ask Dr. Loh, we heard of some people who have died shortly after COVID vaccination. How does KKM decide that they didn't die of COVID vaccine side effects or adverse reactions? Dr. Loh, any comments?
Okay, as what we try to highlight in this webinar, please report all the adverse event, severe adverse event in particular. If you happen to know about death or any severe adverse event, please report immediately. As I mentioned earlier, we had to report within 24 hours, followed with a complete written report, whereby all the report were handed up to the central, and there will be pharmacovigilance committees whereby they will look into the report and work closely with the hospital to investigate the cost, to see whether there is only a coincidence or is a causal relationship between the vaccine and the death or the end event. So meaning that we need to accumulate a lot of information, okay, send it out, discuss, let the pharmacovigilance committee investigate. Then they will come up with the conclusions. Of course, I think they will look into various scenarios. Okay, from the presentations of the vaccines recipients, okay, and the history, as well as the risk factors of the vaccines recipient, as well as comparing with the background rates of the incidents.
Thanks, Dr. Lily. Next question, perhaps I will give it to Dr. Ong. Could the hypertension post-vaccination be due to pain or soreness over the injection site? Would you recommend prophylactic painkillers for those with hypertension?
Well, patients with hypertension, there are a lot of causes that can cause someone's blood pressure to increase after vaccination. It will have to be depending on how was the patient's blood pressure control prior to the vaccination. And of course, stress, anxiety, pain can also increase their blood pressure. Prophylactic painkiller, as already recommended by CDC, it is not recommended, and therefore, due to the reasons that I've stated before. But if the patient had pain after the vaccination, they can proceed to take either paracetamol or NSAIDs at their own preference.
Perhaps if I could add, I think all of us in the panel have been vaccinated, and I think most of the healthcare workers out there listening to this have been vaccinated. And I must say that yes, although after the vaccine, many of us had arm pain a few hours before, but the vaccination itself, I thought was fairly, the pain was really very small. And the needle going in, I thought that one was that the pain was very little. So I don't know, I personally wouldn't suggest a painkiller before there any vaccination. Yeah. Okay, one of the questions was, what if a patient is on warfarin and has an INR of more than 4? How many days should the drug be stopped prior to the vaccination? Is another INR measurement required? Dr. Veena, you comfortable to take this?
Yeah, okay, thank you very much. So basically, I guess if you stop it for about 3 to 4 days, INR should come down. I think if we've had a very stable INR in the background, it's relatively okay to go ahead without doing another INR measurement. But I think it's always prudent to have one prior, because you need to know once you inject yourself, once you get the vaccination, you want to then start back warfarin, and you want to know what your INR is prior to starting, so that you have a rough estimate or rough gauge. So I would say stop for 3 to 4 days, get an INR. If it's between 2 to 3, then you can actually go and get your vaccination. And then once there's no problems, no bleeding, start taking the warfarin at the same dose that on that evening itself. I hope that is clear.
Thanks, Dr. Veena. Yeah. Okay, there's a question on how many COVID vaccinated people in Malaysia have had severe side effects. I don't think any of us have got these the numbers before us currently, because I think these numbers will go up to the through the AEFI adverse events following immunization pathway. They will go up to the NTRA committee, the National Pharmacological Regulatory Authorities. So they will be compiling this severe side effects, and then once it reaches a few cases, then they will be called. They will call the panels to look through those cases. So I don't think we've got any figures for you currently. Let's see what other questions are there. Can we get the email again? I think it can be posted when we report when we send out the slides. Okay.
Sorry, while you're looking through the question, I just wanted to add on something about patients who are warfarin or those with higher bleeding tendency. Please make sure that you compress the injection site for at least 10 minutes, and make sure that you keep looking out for any signs of a hematoma after that. But it's very, very rare. People have actually taken the vaccine while on warfarin without any complications. But having said that, it's always good to keep an eye and make sure you compress immediately post injection for at least 10 minutes. Sorry, just wanted to add that on.
Okay. Dr. Ong, what would you recommend for a patient who had migraine for 7 straight days after first dose of Pfizer vaccine? Is it safe to take the second dose?
All right. So migraine attack can happen or flare up after the vaccination. Typically, if they do occur, they occurred around the first 36 hours after the vaccination. And during this time, the patient, depending on the situation, on whether the migraine attack is mild, moderate, or severe, if it is mild, then paracetamol and rest might be adequate. If it is moderate, then NSAID as well as Maxolon. If it is severe, then certain patients might already have to be on sumatriptan. It's not contraindicated to take during the attack. And it's very important to treat the migraine early rather than sit on it and do nothing, because otherwise migraine attack may progress and the patient might have a full-blown migraine attack, which is very difficult to treat later on. And most of the migraine, based on expert opinions, they do last for 3 to 5 days. However, if the headache lasts longer than that, perhaps that is when we have to consider whether or not the patient might have other signs and symptoms of red flags that we should look into, and then probably advise them to go to the nearest hospital for checkup. And that might be safer than to continue to treat the condition as a migraine flare. That's my opinion.
Dr. Veena, is the PF4 test indicated for high-risk groups before AZ vaccination? And in view of possible IVIG use, should AZ vaccination be done in hospitals?
Okay, so as we know, vaccine-induced thrombotic thrombocytopenia is the vaccine-induced. So basically, you expect that these antibodies wouldn't be present prior to vaccination, because it's an immune trigger basically to the vaccine. So there's no real indication to do it prior to vaccination, because it is something that develops after being exposed to the vaccine. Secondly is that use of IVIG, I mean, essentially all this occurs after 3 days, three days to up to 30 days. So there is no real indication that this test need to be done this vaccination needs to be done in a hospital, number one. Of course, if they need treatment, they need to be treated in the hospital, number two. And number three is that there is currently no guide or inclination of who will develop it and who wouldn't develop it. So it still remains a question mark, and we cannot identify those at high risk of developing VITT at this moment. So we will have to just go on with the vaccination as how we would, but look out, knowing at the back of our heads that this is a possibility, and look out for it. That would be an advice.
Okay. And maybe since I've got you on the line as well, Dr. Vina, this last one is the ELISA test for oh, sorry, I think I accidentally clicked it off.
I saw it. Yeah, I saw it. Was it only in Hospital Ampang, and whether other states have it? So to the best of my knowledge, there isn't any available in other states. We have been offering the SID assay for a long time and no other place in the country at this point in time. I don't know whether other labs are planning to do it in the future, but at the current moment, it's only Hospital Ampang. And it's at our lab, the Clinical Hematology Reference Lab, MLKH.
Thanks, Dr. Vina. Dr. Loh, there was a question for you, which I can't find now. What precautions should we take for those who have an underlying medical history, like the diabetes and hypertension, IHD, if they receive their vaccines?
All right. If a person were to have all these concomitant medical conditions, if you remember my slide or presentations by Dr. Ben last week, they are considered to be under the priority group, meaning that they should get the priority to be vaccinated. So, meaning there's no contraindications, okay? If you have all these medical conditions, you please, you are encouraged to sign up, okay, and volunteer yourself for the vaccinations.
Just on a personal note, my 90-year-old father with diabetes, hypertension, and IHD had his vaccine done yesterday. Okay. Is it true that, oops, sorry, I seem to keep pressing the wrong buttons. I think there were some reports about NSAIDs not being recommended after a vaccine. Do you have any comments about that, Dr. Loh?
Not that I know of, that NSAID is contraindicated post-vaccinations, to my knowledge. Anyone can help me, but to my knowledge, there's no contraindications at all. But of course, you wouldn't take NSAID unless it's deemed indicated, for example, severe pain.
Okay. There are some questions on pregnancy and breastfeeding. I think that will be handled in the subsequent, I think in the last webinar that we have 2 weeks from now. And some questions as well on allergies that will be covered in the next week. Otherwise, I think maybe for a last question, I have arrhythmia. Recently, I was refused vaccination in a community center and told to go to a hospital. How will the arrangement process be for my case? Dr. Loh, are you comfortable with that?
Okay, I'll try my best, because I think every state, perhaps their system might be slightly different here and there. So I suggest that if perhaps you may have to go back to the healthcare facility that's been taking care of you, so the doctors will do the PVA assessment, pre-vaccination assessment. So from the assessment, they'll decide whether you're a suitable candidate to receive the vaccination in community versus the hospital. So the answers meaning that someone will have to carry out the PVA assessment.
Right. Again, on a personal note, I personally have encountered a few patients with arrhythmias. I've discussed this with some of the cardiologists, and all of them are unanimous in saying, and arrhythmias, no problem, go ahead and receive your vaccine. You actually don't need to have any pre-vaccine assessment. Okay. All right. I think there's a few requests for the email for reporting for any adverse events. I will work with the organizers to make sure that that information comes out. Yeah. Dr. Loh, would you happen to have that email address right out? And I'm not sure how we can post it, but it is on your slides, isn't it?
Yeah, I didn't spell out the email address incomplete in my slide, but you just have to go to the NPRA website. So you click under consumer. From there, you look for the AEFI reporting. Yeah, you should download the hard copy of the form. If you're in, you can either submit online or post it or email it or even fax it.
Thanks, Dr. Loh. And for those of you who are working in hospitals, reach out to your pharmacist colleagues. All of them know about NPRA and the forms that are needed to fill in whenever you have an severe adverse reaction to any medications or vaccines for that matter. All right. Okay, with that, I think I'll bring the session to a close. Thank you very much again to the three speakers, Dr. Loh, Dr. Ong, Dr. Veena. Do join us again next week at the same time. Next week's topic will be on allergies and anaphylaxis concerns about COVID-19 vaccines. And so they will concentrate on the risk of allergies and anaphylaxis from studies, and recognizing how do we recognize anaphylaxis, and setting up your vaccination center to prepare for anaphylaxis, and lastly, a quick overview on management of anaphylaxis. Okay, with that, I thank you, and we will see you next week.